As I have said many times, time flies like an arrow, fruit flies like a banana. And it's time for another Persiflager's Puscast. Review the infectious disease literature with occasional snarky commentary. This one is going to cover the papers that were released between January 1st and January 15th, 2012. It's 2012. The world ends in a mere 12 months. As always, this is brought to you by Pusware LLC, where you can find the Infectious Disease Compendium, a Persiflager's Guide, over at my growing multimedia empire, moremark.squarespace.com, where you will find links to my blogs, my books, my podcasts, and my blood type. As always, the references are also available on the website, and we're going to move on right away to the literature. The problem is going to be this is going to be a hard one to keep short this week. Usually I pull down like 80 articles and talk about 20 of them. This time I found 100 articles, and I think I want to talk about all of them. But if I talk about 100 articles, that's going to drag this thing out interminably. I figure most people can tolerate at most 35 minutes of my voice. So let's see how well I can talk quickly and edit on the fly. Now, I am somewhat sanguine about bacteria. Some people have the 5-second rule. I have the 5-day rule. I figure if there's no ants crawling on the food, I'll pick it up and eat it. Now, they like to culture things and freak people out. And this particular study is called Study Finds Bacteria in Unused Paper Towels. And what they did was they cultured paper towels like you find in the bathroom. And they had bacteria on them, mostly Bacillus species, including Bacillus cereus, which we know causes food poisoning. But it's funny because they say B. cereus has been associated with infections in eyes, lungs, blood, and central nervous system. All true if you inject the organism in your blood. If you're going to be injecting paper towels, well, man, you have more things to worry about than bacteria on the paper towel. Everything has bacteria on it. I don't think I'd fret too much about paper towels or anything else for that matter, but it sure is designed to make you paranoid. Emerging infections always has etymologia, where words come from, and they mention this month where the word prion or prion comes from, P-R-I-O-N. It's from protein, P-R-O, and infection, I-N. One thinks then it should be P-R-O-I-N or proin, not prion. So perhaps the Nobel laureate who came up with this name had a little dyslexia. And it's pronounced evidently prion, though I've always pronounced it prion. Of course, I pronounce it cefazolin, not cefazolin, so what the hell do I know? As I do this podcast today, it's actually snowing here in Portland. We could really use a little global warming. Well, maybe not. Since dengue is coming north, they report a dengue outbreak in Key West, Florida. They had 3 cases of dengue, but they found that 5% of the residents had serologic evidence of dengue as well. With global warming and the spread of the mosquito, dengue could easily be coming further and further north as high as Canada. And to give you an idea, there's a nice historical review of a dengue outbreak in Athens, Greece in the 1920s. 90% of the population got sick in Athens, and 1,000 people died, 1,500 dying in the entire country. So when dengue hits an area, given the propensity of mosquitoes for biting people, it can cause a huge amount of disease. But I keep an eye out for these diseases that are coming north every summer, the mosquito-borne ones especially, since I expect I will probably see a case before the end of my career. There's a study out of Australia that shows that indigenous Australians have a high incidence of bronchiectasis, and it is interestingly associated with HTLV-1 infections. Evidently, indigenous Australians have both a high incidence of HTLV-1 and a high incidence of bronchiectasis with a poorer than usual outcome. They hypothesize that it's probably a combination of pulmonary inflammation by HTLV-1, which can be found in high amounts in respiratory lymphocytes, perhaps combined with genetic and socioeconomic factors that leads to both the increase in bronchiectasis as well as the worser outcomes seen in that population. It would be most interesting to recapitulate this study in another population to see if it holds true outside of Indigenous Australians. A couple of years ago, there was an article that suggested that HIV was becoming more virulent. I always thought that it was about 8-10 years between acute infection and symptomatic HIV, give or take. It probably depended in part upon the strain and it depended upon the host. This study looked at the issue of what happens when you treat acute HIV disease. What is the benefit? They randomized people to receive HIV medications either immediately within 6 months of their HIV seroconversion, or to watch them. Those that got antiretrovirals had a much slower progression, only 10% reaching the point where they would normally start antiretrovirals. Interestingly, during the 36 weeks that the patients were followed, 50% reached the point where they needed HIV medications, which is interesting. That suggests that people who have acute HIV may need treatment much sooner than hitherto suspected. Not unsurprisingly, those who are on medications had lower viral loads and higher CD4 cells. So perhaps there may be more benefit in treating HIV earlier, especially as it appears that the bug is a bit more virulent than it used to be. The good news is, he says with a great deal of irony, is that vaccine-preventable diseases are coming back. And who knows, maybe I'll actually see a case of measles before I end my career. On the vaccination front, there are 3 things to note. One is that giving the mom and only the mom postpartum DPT does not prevent the infant from getting pertussis. So, gasp. You need to make sure everybody in the household is vaccinated as well. Also, as you probably know, there's been a resurgence of measles in Europe. Thank you, Jenny McCarthy and David Wakefield. Is it David Wakefield? Donald Wakefield? I don't remember. He's the guy who had the discredited article in The Lancet that said that measles vaccine caused a gastroenteritis that subsequently led to autism, which was a hunk of fetid dingo's kidneys. Anyway, since 2008, there have been 20,000 measles cases now in Europe, 9 measles-associated deaths, and that is in France alone. Interestingly, they had a case of fatal measles in a normal adult in France without a rash. So, thanks to a loss of herd immunity, like Slim Shady, measles is back. As is mumps. And they've looked at the data from the mumps that's going on in Europe, specifically in the Netherlands. No, it's Andrew Wakefield. God, I'm getting senile. I should have looked that up before I did this. Anyway, they asked the question is, what efficacy does the mumps vaccine have in protecting adults greater than 12 years old from getting orchitis? One of the problems with mumps is when there's a resurgence in an unvaccinated population, it tends to jump over, again due to loss of herd immunity, into a vaccinated population. And they found that it decreased orchitis by about 70% in them what had the vaccine. So, although hopefully those that are anti-vaccine get mumps orchitis and don't reproduce as a consequence. That's a terrible thing to say. And now for something completely different. Well, flu stuff. A whole bunch of flu articles. The first is another study to show the benefit of statins. Statins reduced mortality in patients who were admitted with influenza. Again, there's a lot of potential confounders in that kind of information, but it's getting to be the point where both statins, antidepressants, and probably birth control needs to be regularly in the water. I've often said that there's no disease that hasn't been treated with steroids with the possible exception of Cushing's. And I bet you people even tried steroids for Cushing's disease. This study looked again at the efficacy of corticosteroid therapy in primary viral pneumonia from H1N1, and it did nothing. So there's a disease where the patient doesn't need to die on steroids. There was, unfortunately, 2 big outbreaks of influenza after the tsunami in Japan. So crowding people is a good way to start outbreak. Next up, now, those of us who have a thing about the medical literature realize its lack of perfection. Few things in life are perfect, and every clinical trial has some often hidden bias in how it was conceived, done, and interpreted. And it makes the data always a little bit, not suspect, but you have to take any result with a grain of salt substitute. They looked at the potential biases in effectiveness of the flu vaccine in children. And they found, and this is what was most curious, that bias in the clinical trials tended to underestimate the effectiveness of the flu vaccine. I had always thought that bias tended to overestimate effect, but they estimate the true effectiveness to be about 11% higher, at around 88%, than is seen in clinical trials. And so I have to change my thinking about the effect of unsuspected bias in clinical trials. I thought it made interventions more effective than they actually are, and for some reason never considered that they could make them less effective than they actually are. Of course, I wonder if the same thing holds true for adult influenza vaccine studies. What's the best way to prevent herpes? Unfortunately, not the vaccine. There was a study in the New England Journal of Medicine showing, unfortunately, a vaccine was not beneficial in preventing genital herpes overall. It was somewhat beneficial in preventing herpes simplex 1, but it did nothing against herpes simplex 2 for developing genital disease. So you got your suppressive therapy, right? Well, this study was published in The Lancet, and they looked at several doses of the VIRs, 400 BID of acyclovir, 500 a day of valacyclovir, 800 TID of acyclovir, and a gram 3 times a day of valacyclovir, and looked for disease. These were all better than no therapy, but unfortunately, even on therapy, people still had PCR positive swabs. It was a remarkable study in that they had 113 participants randomized, and they collected 23,605 swabs looking for herpes. Ugh, I wouldn't want to participate in that. This is here, patients collected genital swabs 4 times daily. Ugh. But they found no matter what you were on, you had subclinical reactivation of herpes simplex. The higher the dose, the lower the viral load, but you still remain potentially infectious even on high dose of the VIRs. The higher doses was more effective than the lower doses, which is probably more effective overall than the placebo, but still, wear a condom. Because it would appear that the VIRs are not sufficient to prevent reactivation entirely and therefore prevent the spread of herpes simplex. Latex is still better. Sometimes you read an article and your reaction is, say what? All right, this looked at 86 cases of MRSA meningitis. It was published in the journal Medicine. Now, most patients had some sort of underlying neurosurgical problem, but it did occur spontaneously. And as they say, it's relatively uncommon but serious. But here is the interesting result. Now, most patients received vancomycin, mostly monotherapy. Some got other antibiotics. And overall 30-day mortality was 31%. 1 in 3 people who developed Staph aureus meningitis died, especially if you had spontaneous meningitis. So what do they say in the conclusion? Well, it says, most patients have a favorable response to vancomycin. What? And it's associated with a high mortality. What? How can you have a favorable response in most patients but have 1 in 3 die? I don't know. That doesn't seem to make a lot of sense to me. Unless I suppose you have family members in the mortuary business. So, how do you treat MRSA bloodstream infections? Well, usually vancomycin. But as the MIC to vancomycin goes from 0.5 to 1 to 1.5 to 2, efficacy rates fall to the use of vancomycin. Interestingly, in that Australian study we talked about a month ago, if it's MSSA with elevated MICs to vancomycin, as the MIC goes up, your efficacy to beta-lactams falls. So perhaps you should use another agent. How about daptomycin? This was retrospective with all the problems in retrospective studies, and it was case-controlled. And they looked at outcomes in patients who had daptomycin or vancomycin due to Staph aureus with high MICs, greater than 1. And they found that daptomycin had a better outcome. That's interesting. The clinical failure rate of daptomycin was 17% versus 31% for vancomycin. And the death rate was 9% in the daptomycin group versus 20% in the vancomycin. The daptomycin was given at 6 milligrams per kilogram, by the way, and they pushed the troughs of the vancomycin. So if you have an MIC greater than 1 or less than 2, at least based on this retrospective study, more data to suggest that vancomycin is not the best drug, but perhaps daptomycin for now. The downside to dapto, of course, is that resistance occurs on therapy. One still wonders, me being one, about the new 5th-generation cephalosporins like ceftaroline, and ceftobiprole or ceftobiprole, however you pronounce them. But there are currently no bacteremia studies published. And of course, this was not a prospective randomized blah-de-blah-de-blah trial, so the results are always in doubt. But further evidence to my mind that if your MIC to vanco is above 1, maybe even at 1, you should use something other than vancomycin, the ultimate in crappy drugs. You don't think of pneumococcus as causing lung abscesses or necrotizing pneumonias, or do you? This study looked at 351 cases of pneumococcal bacteremia. Nobody saw necrosis on the initial chest x-ray and on only 4.4% of the initial CTs. So they went back and harangued the radiologist. Come on, really? You must see something there, don't you? And they found 2.3% of the initial chest x-rays actually had necrosis, and 11% of the CTs had necrotizing changes. They found the overall incidence of necrotizing disease to be about 6.6%. The only real difference was type 3 pneumococcus, which was most likely isolated. Now, I did search of the paper and didn't find any reference to nonsteroidal anti-inflammatories, but there was a recent article that suggested that patients who had NSAIDs were more likely to develop lung abscess and empyema. This wasn't looked at in this particular article, but one would wonder, wouldn't one, that these patients were perhaps taking NSAIDs when they had the onset of the pneumonia. But it reinforces the importance of going over the x-rays with the radiologist, telling them what you're looking for and why. They often see more under those circumstances. Too often they're forced to read their studies blind. By the way, if your carbapenem of choice at your hospital is currently doripenem, don't be using it for your ventilator-associated pneumonia. They were doing a study comparing doripenem with imipenem, and they found that those who were on the doripenem had a 21% all-cause mortality versus 15% for the imipenem, which evidently is generic, about time. So if you're using doripenem for your ventilator-associated pneumonia, don't. Again, unless you're family or a bunch of morticians. So you send your patient home with C. difficile. Is their family at risk? Well, they looked at the risk of 1061 spouses and 501 children who lived in the same household with an index case. Of those, 5 spouses and 3 children developed C. diff, giving an attack rate of 4.7 per thousand for adults and 5.99 per thousand for children. And the relative risk for the 3 months after the diagnosis was 7.6. They think it was too low to do anything except to not give, quote, unnecessary courses of antimicrobials, unquote, which is what we all do, isn't it? Well, the family member has C. diff. Let's give everybody some clindamycin. I had a patient who developed C. difficile shortly after Thanksgiving dinner. She was on PPIs, and her sister-in-law was making the Thanksgiving turkey and had C. difficile. So it can be spread perhaps by more than just the use of inappropriate and unnecessary courses of antibiotics, but that's an anecdote. And we all know what the plural of anecdote is, don't we? It's anecdotes, not data. What is the best treatment for cryptococcal meningitis? Well, you may get some arguments among ID docs. I remain of the opinion that your best bet up front is high-dose amphotericin, about 0.1 to 1 milligram per kilogram, plus 5-flucytosine. Evidently, 5-flucytosine is not available in Asia and Africa. So they did a trial where they compared amphotericin plus 5-FC to amphotericin plus fluconazole, 800 a day, or amphotericin plus fluconazole, 600 a day, or amphotericin plus voriconazole, 300 BID. And they found no difference in outcomes. And think that amphotericin plus fluconazole, 8 to 1,200 milligrams a day, may be your best bet for the treatment of cryptococcal meningitis in places of the world where there's no flucytosine. And what, of course, are the 3 most dangerous words in medicine? In my experience. That being said, in my experience, when treating cryptococcal meningitis, it's less often the amphotericin that's the rate-limiting drug, but the 5-flucytosine. 5-FC tends to make people quite ill, and when you get the blood levels into the appropriate area, they get cytopenias and toxic megacolon. And I've always had a great deal of difficulty in getting patients to take their 5-FC. Fluconazole is much better tolerated. What makes this the best infectious disease podcast out there? I think it's my commitment to staying under a half an hour, or at least no more than 35 minutes. We're at 23 minutes-ish now, and so I'm going to do what I've done in the past, which is a hodgepodge, which just go through a whole bunch of stuff and basically not go into great detail. I'm sure by now you know how to use Google. It was just sort of cool that they dug up a corpse from the Italian Renaissance in the 1500s, and they found Leishmania infantum. You think I know how to pronounce these as a job. In the cadaver of Eleonora of Toledo, the wife of Cosimo de' Medici. Now, I guess Italian names are not my strong point, but I think it's cool that they found Leishmania in her corpse. And there's still Leishmania in Europe. There's been cases now reported in southern France, and Leishmania is going north. So if you're going to travel to France, remember that there is leishmaniasis now in the south of France. There's a review in CID about whether or not to treat blastocystis. The answer is, well, if they have a ton of blastocystis in their stool and they have symptoms, treat them with metronidazole. Otherwise, if it's just a few cysts, ignore them. Nocardia, how much Bactrim resistance? They found only 2% were resistant in the United States to TMP sulfa and or sulfamethoxazole. So I always thought it was higher, but there seems to be a lack of quality control in the testing of Nocardia species, and that perhaps Bactrim resistance is not as high as otherwise reported. This study looked at how often you should check transaminases in people on TB therapy. I usually give patients the word on what symptoms to look for, and then we check their transaminases. However, this study suggests that everybody get transaminases tested at 2 weeks for prompt identification of tuberculosis therapy toxicities. Especially if you're going to Swaziland. Why do you care about Swaziland? Well, they have a ton of MDR-TB at rates of, get this, 7.7% of newly diagnosed tuberculars and 34% of previously treated tuberculars. If you go to Swaziland, don't inhale. Archives of Internal Medicine looked at the overtreatment of enterococcal bacteriuria. Too many asymptomatic bacterias were being treated, and they said, stop it. Of course, it's hard for most people to ignore cultures. I sometimes think I'm the only person allowed to ignore bacterial cultures. They find Babesia in the United States. We all know about Babesia. It would appear that the states with the highest Babesia rates are Connecticut, Rhode Island, New York, and Massachusetts. My eldest son is currently at Syracuse, and now not only do I need to worry about Lyme disease, I got to add Babesia to the list. Well, he's not much of an outside person, so I'm probably safe. Reintroduction of the rotavirus vaccine has not seen a rise in intussusception. Good. This study compared doxycycline plus a beta-lactam versus macrolides plus a beta-lactam for community-acquired pneumonia. It found no difference in outcomes. I tend to believe in the immunomodulatory effects of macrolides are what show the increased efficacy of macrolides plus beta-lactams in the treatment of antibiotics. There are very old studies of pneumococcal pneumonia, as I remember it, that show the superiority of tetracycline over penicillin for the treatment of pneumococcal pneumonia. One would wonder again as well about immunomodulatory effects. Another study in a veterans group, those who are on PPIs had an increased risk of community-acquired pneumonia. So if you're going to give them PPIs, give them doxycycline as well. That's just a joke. Don't give them inappropriate antibiotics. They'll just get C. diff. Group B strep is a problem, of course, in adults. We see this occasionally in people who are not pregnant, and they all have immunosuppressive states, and not infrequently go on to develop meningitis and, here was my surprise, endocarditis. Of the 10 patients with bloodstream infections, 3 had endocarditis. Most of the time when I have a group B strep in the blood in an adult, because they have underlying immunodeficiencies, I don't worry particularly about endocarditis, but treat the hell out of it anyway. Should I get more echoes? I don't know. But a 33% endocarditis rate is one to give you pause. Speaking of cadavers, they unearthed some corpses, specifically skulls. They took out the dental pulp from the 1600s and found plague in it. This is another study where they found bubonic plague DNA, Yersinia pestis, in the dental pulp of plague victims, which is really convincing me that indeed the outbreaks of the Black Death were due to Yersinia pestis, though there is an argument against it that I've always found somewhat compelling. In 2009, there was flooding in the Philippines, and there was an outbreak of leptospirosis. Remember, wherever anybody is in water, especially if they inadvertently swallow it, they get leptospirosis. They had 471 cases with 11% mortality rates. There was a case of endocarditis due to Legionella longbeachii. I only mention this because longbeachii is associated with gardening and the handling of potting soils. And that makes that particular Legionella unique, especially because it's associated with composted wood products. My wife has a huge compost pile in the backyard that she's always asking me to crawl into for some reason. People think just because you have money, you can't get trench fever. This was out of Czechoslovakia, where a wealthy family all developed Bartonella quintana, trench fever, from a mite bite. Now, y'all know that you get hepatitis E from pigs and eating pig products like pork. Well, no, of course like pork, but especially liver and sausages. They looked at the incidence of hepatitis E in rats around pig farms. And I would think even a rat would not want to be around a pig farm. I mean, those are one funky smelling area. But they found evidence of hepatitis E in wild Norway rats 18% of the time. So the rat could be a good vector for taking hepatitis E from pig farm to pig farm. In Malawian patients with bacterial meningitis, if they had positive PCR for EBV, they had a much higher mortality rate. That's interesting. Also, patients who have CMV in their sputum for pneumonia in the ICU have higher mortality rates. One wonders about reactivation of these herpes viruses and what adverse effect it may be having on either the immune system or the inflammatory response in patients with severe disease. The more frequently a patient takes their HIV medications, the more likely they are to have resistant virus, probably because of decreased adherence. So if you can give a once-a-day dosage, that had the best outcomes in terms of the development of resistance in patients who were started on, quote, modern combination therapy. And patients who have a heart attack and patients who have HIV frequently have heart attacks are at a much higher risk of death in the subsequent month. And finally, unfortunately, because the healthcare system is going bankrupt, we don't have to worry about this. But this study was out of Great Neck, New York. And what they did in their ICU is they put up cameras by all the sinks and they videotaped whether or not you washed your hands and probably picked your nose when you were in their ICU. And they found that by doing a combination of video surveillance plus feedback, they had a significant and a sustained improvement in hand hygiene. Here's the part that gets me. They had a 10% hand hygiene rate at the beginning, which is just appalling. I mean, I recognize how difficult hand hygiene can be, but 10%? I wouldn't publish that. I'd be too embarrassed if my institution started out at that level. Now, they certainly were 15 years ago, but this study was done recently. So I think the take-home message is if you're in Great Neck, New York, bring a can of alcohol foam with you and hand it to your healthcare providers. And that ends at 32 minutes and 13 seconds. Your Puscast. See how good I am at keeping your time commitment to 30-ish minutes, including the intro and the outro. This is, as always, brought to you by Pusware, LLC. You can find my growing multimedia empire at moremark.squarespace.com. This is available on iTunes. And if you're listening and you haven't done it, hey, go write me a glowing review. My fragile yet ravenous ego demands it. And you can listen to my other podcasts, read my blogs, read my books, and in general, marvel at the wonder that is me. This is copyright now 2012 under the Creative Commons license. You can email me, but I rarely answer email. I am so slow at typing. It's just tedious, and I just never get around to it. But I do read the emails. Otherwise, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you, in dictation, and goodbye.